Assalamu alaikum wa rahmatullah. Welcome to the 10th lecture of the oral diagnosis course, and today's lecture is one of my favorite topics, which is non-dental pain. And reaching here to this complicated, horrible diagram showing the classification of facial pains or different sources of facial pain. And it shows here axis 1, axis 2, which refers to the psychological conditions that might be presented as pain, any pain in the orofacial area. And this includes mood disorder, anxiety, somatoform disorders, and other conditions. And axis 1, which is more of physical pain, and this can be classified into somatic and neuropathic pain. In the last two lectures, we talked about somatic pain. We talked about the one example of the visceral pain, which is the pulpal pain. Of course, visceral pain include different sources of pain, including neurovascular and vascular pain, glandular and ENT pain. So in this lecture, we are going to present some different types of vascular pain. And also in the last couple of lectures, we talked about one form of musculoskeletal pain, which is periodontal pain. And we talked about periapical lesions, different forms and presentations of the periapical lesions. And this is one example of the musculoskeletal pain, sort of a deep pain. And there are different sources of musculoskeletal pain that might be presented in a patient, including the TM joint and muscle pain. There is also within the axis 1, there is neuropathic pain, which can be presented as either episodic or continuous pain. So in this lecture, we will, inshallah, present different types of pain that might affect the facial or orofacial area. We're not going to talk about the psychological conditions. These, some conditions we will explore and talk about in the oral medicine course next year, inshallah. And in this lecture, I'll just introduce you to some different types of pain within the neuropathic and within the somatic pain that might affect the orofacial area. So going to this simple diagram, so I'll be talking now about the soft tissue pain that might affect the oral mucosa, the sinuses, or the salivary glands. The dentoalveolar pain was discussed in the last couple of lectures, including the odontogenic pain. Periodontal pain I didn't actually talk about. I just talked about the periapical periodontal pain. But of course, periodontal ligaments in the cervical area might be affected, and the patient might come to you complaining of pain in the dental area. And when you examine the tooth, there is no caries, no periapical involvement, no pulpal involvement, and the problem would be just within the gingiva and the cervical periodontal ligament. So the patient might have localized periodontitis or gingivitis, and in this case it's just the cervical part of the periodontal ligaments are involved. And this is the condition that you will deal with in the periodontology and in the periodontics clinic. So going back here to the first part of our lecture, talking about the soft tissue involvement in the orofacial area. And this includes mucosal injury or lesions. So this is actually the simplest lesions to identify and diagnose, because you can see the lesion and you can identify that there's an ulcer there is a nodule, and there's a growth maybe, and this is the source of pain. When you palpate it, when you press on that lesion, this will induce pain. So it's easy to localize. There is no referral. The pain does not refer to different site, and there is nothing hidden. So as you can see here, when the patient come to you complaining of pain in his tongue and you see this lesion, you can identify, well, this is a big ulcer, this is probably the cause of pain. And the pain is usually presented as a burning sensation, as soreness in the area. This can be due to trauma or injury. So the patient might have, bit his tongue or burned his tongue eating, with a hot drink or with a hot piece of pizza, for example. Or it might be related to a disease. Different mucocutaneous conditions or diseases might be presented in the oral cavity. Some of these that you have discussed in the oral pathology, and we will also reinforce the clinical presentation of these conditions in the oral medicine course next year, inshallah. So soft tissue involvement in the tongue, in the mucosa, in the buccal mucosa, and the floor of the mouth, all of these can be seen, can be detected clinically, and it will heal when the lesion disappears. When the ulcer heals, that's it. There's no pain. And examples include traumatic ulcer, which is the most common cause of ulcers in the oral cavity, autoimmune diseases like pemphigus and pemphigoid, or infections. So that was straightforward. More challenging condition is the sinusitis. And when the sinuses are infected, you cannot see that. You cannot see any lesions within the sinus. And why are we talking about sinusitis? Because it might be presented as a dental pain. So the patient might come to you complaining of pain in this area. For example, he will tell you that all my teeth are aching. I cannot localize any tooth. I just feel pain in all of my teeth. And when you examine the teeth, you see everything is okay. There's no caries, nothing. When you do percussion test, it is painful, and all of the teeth are tender to percussion. So this indicates maybe there is something not related to the teeth. To make sure, to double check, you just took a periapical radiograph, and here you go. There's nothing. There is no caries, no bone loss. So this indicates or rule out that the cause is dental. Keep in mind that infection or inflammation within the sinus can induce pain felt in the teeth. And this is sort of sinusitis, we call it silent sinusitis. So the patient is not presented with the typical presentation of sinusitis, of heaviness and purulent discharge coming from the nose or postnasal drip. This might not be clear to the patient, and all of what the patient feels is pain in his teeth. And this is because when there is infection here in the sinus, when there is lots of fluid retention, the lining of the sinus would be inflamed, and this would affect the bone here, that is where the roots are. So it's very close to the root. And also another thing, the nerve, the superior alveolar nerve, will pass through the maxillary sinus before it gets to the apical foramen here to supply these teeth. So when there is an infection in the sinus, the superior alveolar nerve would be inflamed, and this will make the teeth sensitive and sensitized to pain, and will make the patient would feel pain in his teeth. So there are two causes of pain when there is sinusitis. First, the close proximity. There's inflammation in the mucosa here, and this might affect the bone, which is close to the teeth. So this area would be inflamed. And the other cause is neurological cause, that the nerve, the superior alveolar nerve that supply these teeth pass through the maxillary sinus, and it would be affected with the inflammatory mediators and cytokines that are present here, and it will be inflamed. So it's a case of neuritis where there is inflammation of the superior alveolar nerve. So this will lead to the pain in the teeth. The take-home message is that when there is no evidence of dental pain, do not go just proceed and do a dental treatment. This is the message that I will keep repeating after each single condition that we will discuss. So here there's no evidence of a dental pathology. Think of sinusitis. Ask the patient about any congestion, for example, recent common cold infection, any postnasal drip that the patient might notice upon waking up. So the patient might not relate this postnasal drip to his dental pain. So be vigilant to these changes, which indicates the presence of a sinusitis as a cause of a dental pain. All what you need to do is just refer the patient to the ENT doctor to rule out sinus infection. So this is one example. Salivary gland disease, and in this case we usually refer to infections, either viral or bacterial infection might affect the salivary gland. And when the clinical presentation is not yet clarified, when during or at the initial stages of the infection, the patient will complain from hazy, diffused pain in the area, and he might think that he has maybe his third molar, or maybe there is an infection or a dental infection, until the clinical symptoms would show up that there is an infection, either viral or bacterial infection. Here this image shows probably bacterial infection in the parotid gland, and the reason why I thought of bacterial, because the skin looks red. In a viral infection, the skin does not look red, it is just swelling. And here it's affecting the parotid gland area. So now we can, say it's a parotitis or bacterial sialadenitis. And because we can see the swelling, we can see the red skin. However, at the initial stages, symptoms might not be clear and might be confused with the dental pain. The third cause of facial pain is the musculoskeletal, and here I'm presenting arthrogenous and myogenous. Arthrogenous, arthro means the joint, so the pain is originating from the joint, or myogenous. Myo means muscle, which means that the pain is originating from the muscle. The TM joint pain, usually the pain is located in the joint area, refers to the ear in many instances, and the patient will tell you that talking, chewing would induce or increase the intensity of pain. This pain can be caused by the dentist, and the reason why is when you have a patient and you ask the patient to open his mouth, just open widely, and you start working on the patient's teeth, the patient might remain or keep his mouth open for, it depends, during the 4th year usually the patient would stay the whole 3 hours opening his mouth. In the 5th year you might be a little bit faster, so 2 hours would be adequate. Hopefully 2 hours would be adequate to finish your dental work. 2 hours or 3 hours is a huge amount of time to keep the patient's mouth open. You need to give your patient a break. You need to, ask the patient to just close a little bit. And if you are concerned about the saliva control, you can put the suction on the patient's mouth and ask the patient to just close slightly. You can use the cotton rolls to control the saliva, but you cannot ask the patient to keep his mouth open for the whole 3 hours or 2 hours. This is too much, and this will induce a massive load on the joint, particularly if your patient is already he has a bad joint. He has the most common condition is the disc displacement, where there is a click in the joint, and when the patient comes to you, keeps his mouth open for 4 hours or 3 hours, and when you finish, the patient will would have a severe pain in his joint, and will have this pain for long 2-3 weeks afterward. So pay attention to that. Pay attention that you need to finish your work as good as possible, as efficient as possible, and as quick as possible. And this is why you need to work hard, train hard on doing the dental work and to practice dental work. So if you feel that you need more practice, just go on practice on the phantom head rather than practicing on your patient's mouth, because this would damage the joint and will also affect the muscles. The main muscles that would be affected are the temporalis muscle and the superficial masseter muscles. So all of these might be affected so when doing dental work for a long time. And hopefully, if you are a good dentist, if you manage to master the TM joint mechanistic action, how it works, what are the diseases, what are the problems that might affect the joint, and how to deal with them, how to treat them, you will be able to manage most of the TM joint conditions, simple conditions. We will talk about the TM joint pain, its mechanism of action, the different diagnoses, whether it's just inflammation causing a capsulitis, or a disc problem that would cause disc displacement, or maybe arthrogenous, which means like the joint itself now it's affected and the patient is developing arthritis, or maybe the patient have a reasonable joint and in a good health, but the problem is myofascial or within the muscles. So these simple, straightforward conditions, which affect more than 80% of the patients complaining of the TMD, you might be able to manage them. The muscle pain is of particular interest because sometimes when there is a hyperactive point of the muscle, we call it a taut band. And when there is a taut band at the muscles, at the facial muscles, this might be presented as a dental pain. This is the temporalis muscle, and the sign X here refers to the site or location of the taut band, the area where there's a hyperactive, tense muscle. So when there is a taut band in this area of the temporalis muscle, the pain would be felt just above this taut band, maybe above the eyebrow, and also it might refer to the anterior tooth. So the patient would come to you complaining of pain in this area and in the anterior teeth, and he would tell you that I have pain in this tooth, referring to or referring to my forehead. So you will go on, examine the tooth, check if it is tender to percussion, check the vitality, do radiographs, things would be clear. But keep in mind that this might be just a referral from a taut band in the temporalis muscle. This is at slightly backward, and these dotted area shows the area of referral where the patient would feel pain. So the patient might feel pain in this area and in the premolar area. Here, as it goes more backward, the pain is referred here and to the molar area, and here the pain is referred to the parietal area of the head. Another example of muscle pain that might be presented as dental pain is taut band here in the superficial masseter. The patient would feel the pain in his teeth. So when you press at the taut band, when you do extraoral examination, and when you palpate the masseter muscle and you feel this taut band, the patient will feel the pain on his teeth. So when a patient comes to you complaining of a dental pain, you did comprehensive dental examination, there is nothing in his teeth, go ahead and examine the muscles of mastication. So probably, or it is possible that the pain is referred from the muscles of mastication. Here again, the taut band are located a little bit lower in the masseter muscle, and the referral is to the lower teeth. Here, the taut band is in the deep masseter muscle, and the pain is felt in the ear. So many patients go to the ENT doctor complaining of earache, complaining of pain in their ear, and when they are examined by the ENT doctor, this is ruled out. The ear is healthy, there's no problem with his ear, and usually the ENT doctor would refer him back to the dentist or to the orofacial pain specialist to examine his muscles and the TM joint. Another example here, we have the posterior biliary digastric. Tote band in the posterior biliary digastric would refer the pain to the ear and also to the angle of the mandible. So the patient might come to you again complaining of pain in the angle of the mandible, thinking that it might be the wisdom teeth. So do not just go on and proceed with extraction of the wisdom teeth, hoping that they might be the cause. If there is no problem with the wisdom teeth, just leave him alone and go and check other causes of pain. Probably it's a myogenous pain. And here is the anterior biliary digastric, that when there's a tote band here, it refers pain to the lower incisors. Check the lower incisors, take radiograph, nothing, examine the muscles, and when you palpate at the X site, at the site where there is a tote band, the patient would feel the pain at the referral area. The patient would tell you that when you palpate the anterior biliary digastric, the patient would tell you, yes, exactly, this is the pain, and I feel it now in my teeth. So this would confirm your diagnosis that the pain is muscular in origin. Let's take this case scenario. The patient, of course, would come to you. He doesn't know the cause of pain. He would describe to you what he feels. He will describe to you how the pain feels like and where. So this patient came to you complaining of pain in the upper and lower teeth, in this side, the right side, and this dental pain is causing me a headache. So I feel it in my teeth, and then it spreads all over my head. I can feel it here and in my forehead. I can feel it in my ears. It's all over this area. You need to take a history about the pain, like when it started, how does it feel like, how bad it is. So all of this information you need to check with the patient, what triggers it, what relieves it. So the patient told you that the pain is sort of aching pain, deep pain. He feels the pain whenever he's tired. Maybe when he chew, he would feel the pain in his upper and lower teeth. It lasts for a long time. Usually it is relieved when he stopped eating and stop talking. Taking Panadol would reduce the pain. So you might be, you don't know. Is it dental pain, chronic dental pain? If you did an extraoral examination, if you go routinely on doing the extraoral examination, starting with the extraoral examination, then moving to the intraoral examination, this is good for you, because you would be able to collect all the information, not just the history. You'll go to the of course the medical history, and then you'll go to the extraoral examination. You would be able to examine the superficial and deep masseter muscles, the temporalis and the joint, and you will be able to detect if there is any problem. Presume that you went straight to examine the teeth, and the first thing you did, you looked at the teeth, everything was okay. Then you thought, okay, I'll take a radiograph and check. Maybe I'm missing something. So you took a bite wing and look at that. It's ideal bite wing. There is no even an incipient caries here. It's very clear, very healthy dentition. There is no bone loss. Everything is just perfect. Okay, but the patient feels pain in all of his teeth. So, you don't know what to tell the patient. And if you know nothing about myogenous pain and the muscle pain that might be referred to the teeth, to the upper and lower teeth, you'll be stuck. And the worst thing you can do is, just pretend doing any dental treatment, like treating stains, occlusal stains with a composite filling, or doing scaling and polishing and this stuff, which would definitely not relieve the pain. And it might even makes it worse, because when you ask the patient to open his mouth wide for probably 1 hour, treating unnecessarily stains with a composite filling, and in this case, you're making a big mess. You make the patient's condition worse. You did not treat the cause of his pain, and you made it. You unnecessarily damaged dental tissues. You unnecessarily did scaling for this patient. So it is important to recognize that there are different sources of pain, different causes of pain, even dental or toothache. Let's say there are different causes of toothache other than dental pathology or dental pain.